We've got quite a varied program today. Our first speaker is Professor John Pepper, whom many of you will already know. He's consultant cardiac surgeon and director of research at the Royal Brompton Hospital, as well as professor in cardiothoracic surgery. He's an internationally acclaimed surgical pioneer with a lifelong interest in aortic aneurysm and especially Marfan syndrome. For over 30 years, he's been advisor and supporter of both the Marfan Association and the Marfan Trust. He's going to give his talk about what's new in aortic and mitral valve surgery in two halves. So he'll stop after about 20 minutes and ask if there are any questions. So Professor Pepper, would you like to kick off our day?
Are you able to hear me?
Yes, bravo.
Okay. Okay, well, thank you very much for inviting me, and good morning, everyone. It's a rainy morning, so it's quite good to be doing this virtually, I think. So personalized external aortic root support, and the personalized is an important part of the concept. A lot of you are aware of this. Of course, we're talking about the Marfan syndrome, and although it affects various systems, as you know, the eyes, the skeletal system, and the cardiovascular system, it's the cardiovascular system that is the most dangerous. And there are various measures available to prevent dissection. There are drugs, and you are familiar with the AIMS trial. So why might we want a new approach, which we were thinking about 20 years ago? We decided to try and develop a new technique that we thought might be protective, particularly early in the natural history of disease of the aorta. And we developed this at the Royal Brompton, and I'll give you a tiny bit of the history so that you have some idea. We're going to talk about the economical value briefly and wider application now, way beyond Marfan to other quite complex conditions. And we are now doing this not only in the UK, but in both hemispheres of the world. Okay, so we know that it's a connective tissue disorder, the mutation of the fibrillin 1 gene, autosomally dominant, but of course there can be sporadic cases, and there's familial clustering. You're familiar with all that, and I've mentioned the manifestations. It affects about 1 in 4,000 across the sexes equally, all age groups and all races. So it's about 16,000 patients in the United Kingdom and about 185,000 patients in the European Union. And this is a very rough estimate, but 1.25 million patients worldwide. I'm sure that's an underestimate. So the primary intention that we all want to have is to prevent dilatation of the aorta, particularly the first part, which we call the aortic root, and to prevent rupture or dissection. That's the main target in patients with Marfan. And because of the weakness of the aorta, people with Marfan are at an increased risk. And particularly in women who become pregnant, especially in the last third of the pregnancy, when hormone changes occur, there is an increased risk. So here we have a normal aorta. Here's the aorta. That thing is part of the mitral valve, so ignore that for the moment. That's the main pumping chamber of the heart, the left ventricle. And there's the aorta. And this bit is what we call the aortic root. And you see one of the coronary arteries coming off. That's the right coronary artery. And there's the ascending aorta, and it goes around the corner and down in front of your spine. So that's the normal arrangement. And then if you have a Marfan syndrome, and of course, not everyone with Marfan has this condition, but if you do, then this segment enlarges. And what happens is that these coronary arteries essentially move away from here. So there's quite a bit of space here, something to bear in mind when we were thinking of this new operation a few years ago. But that's more or less what it looks like. And if it's allowed to continue, not only does this bit enlarge, but this bit, and also the ring, what's called the annulus that divides the valve from the main pumping chamber. And of course, the risk of dissection increases just as the diameter increases, just as it would if you were blowing up a child's balloon. And associated with that is, of course, a risk of mortality. Now, this slide in the bottom right-hand corner is a very old slide, but it's the only information we have about the natural history of Marfan. If you have no drugs and you have no treatment and you're just observing what happens to people with Marfan, this was written in 1972, and the males and the females follow a very similar course. But you can see the probability of survival here is 50%. So 50% survival at the age of about 45 to 50 is not a good outlook. So that is information that is old. We'll never get it again, of course, because we're now able to treat people. And this was an operation devised at the Hammersmith Hospital in London a very long time ago by Hugh Henry Bentle, sadly died a few years back. And he put a valve inside a tube, a plastic tube, and connected the coronary arteries. Quite a complicated operation. And initially this carried quite a risk, but is now a very safe operation with a risk of death of 1%, and is the standard way of dealing with an enlarged Marfan aorta. And I expect some of you listening have had this operation. Of course, you could put a biological valve in there, but being biological, it's only going to last 10 or 15 years. Most people have a mechanical valve. So this operation certainly prevents fatal root dissections. So why need another method? Well, first of all, it's a bug operation. It involves being connected to a heart-lung machine. But the real thing is that if the aortic valve is normal, which in some patients it is, and it's not leaking at all, you are replacing it with an artificial valve. And of course, artificial valves, while they are very reliable nowadays, they're not as good as a normal human valve. They will deteriorate if they're biological tissue valves. They are prone to getting infected, infective endocarditis. A minority of patients get this, but if it does happen, it carries a high risk. There's the risk of clots forming on the valve, and they may move, what we call thromboembolism. And of course, if it's a mechanical valve, you're committed to be on warfarin. Warfarin's a tedious drug to take, but you can take it. You have to have blood tests regularly. And the real problem with warfarin is that you are connected to the medical profession by a sort of metaphorical umbilical cord for the rest of your life. And so if it was a way to avoid that, it would be good. And thromboembolism has these unpleasant complications, bleeding or thrombosis. So how often does this happen? It's not rare. It's about 2 to 3% per patient year. That's 2 to 3% every year. So you'll be familiar with Tal Goldsworthy, who is tuned into this presentation. He has Marfan syndrome. His father had a dissection in his late 40s, and he is a chartered engineer who spent his formative years in the National Coal Board, and he involved constructing filters to take noxious gases away. So he knew a lot about filters and the construction of plastic filters, and this played to his strengths. Now, he was being watched at St. George's Hospital, and his aortic root was reaching the threshold for having an operation. But he didn't like the idea of having that Bentle procedure, the root procedure that I just showed you. And why? Why didn't he like it? Well, he didn't like the idea of having a big operation with a heart-lung machine. He certainly didn't want to be on warfarin for the rest of his life. And if he had a tissue valve, of course, inevitably, he would have to have some reoperations because tissue valves are biological, and we know biological things wear out. So what did he propose as an alternative? Remember, he's an engineer. He knows about pipes. He knows about lagging pipes. So his idea was to manufacture an external sleeve that fitted the aortic wall to prevent dilatation and risk of a dissection, to increase the strength of the wall, and to preserve the patient's own aortic valve. And this would avoid the complications I referred to earlier. So in a talk, or in a meeting, sorry, rather like this, in 2000, Tal approached Professor Tom Treasure, who at that time was at St. George's Hospital, and said, "What about it?" And after a bit of chatting, they came to see me at the Brompton. And between 2000 and 2004, involving quite a few other people as well, we did some intense work to develop the PAIRS project. And this little cartoon, of which I'm sure some of you are very familiar, here are images of the aorta. Initially, we used magnetic resonance scanning, but in fact, we found that CT scanning was more precise because the resolution's higher. Magnetic resonance scanning, of course, is radio waves, no irradiation, so we use that for following patients, but for actually deciding how to construct the sleeve, the CT scan's better. So by computer-aided design and a form of 3D printing, we produce this sort of fluorescent green image, and we turn that into a plastic mold, as you see along at this point here. And then we heat shrink this special polyethylene material, which is very similar to the Dacron material that is used to replace grafts. It's the same material, but the design of the textile is significantly different. I'll come back to that in a moment. And then sterilize it, and we place it in the heart. So that's the idea, and that's what we do. So this was a lot of hard work, particularly by Tal, an engineering team, and a medical team, and of course a regulatory team. And we did the first operation in May 2004, and the patient, of course, was Tal. And this is just to indicate you the models taken from the first 20 patients, just to indicate that medicine is the study of abnormal biology in human beings, and a fundamental feature of biology, of course, is variation, something that Charles Darwin realized very much. And notice that every single one of these 20 patients, their aortas are different. So what we have designed here is a personalized sleeve, because the idea of wrapping the aorta was this very old idea. It was done in the early 1920s and the 1950s and was abandoned. But this is not a simple wrap. It is a very precise sleeve. And because this is a computer-aided design, we can make these models 100% or 95% or 90% if we want to shrink the size of the aorta more. And the material itself, as I've said, is very particular. It has 0.7 millimeter holes in it to allow cells, inflammatory cells, to enter. So the sleeve becomes an integral part of the aortic wall and strengthens it. So here you hear a lot nowadays about precision medicine, particularly in the use of drugs in cancer and antibiotics. Here's an example of precision medicine in surgery. It's an example of using 3D printing of organ models. And as I said, the mesh itself strengthens the wall of the aorta. So we did a little study. My colleague, Samil Izgi, led this, as he's a cardiac radiologist. And we looked at 27 consecutive Marfan patients who had this PAIRS operation at the Brompton Hospital. And the question, going back to what I said at the beginning, the real question, is PAIRS really effective in the prevention of progressive enlargement of the aortic root? That's the key question. And so to save time, obviously you start off with 27 patients, there are various exclusions, and 22 patients, in fact, we followed up very carefully. And we measured the size of the annulus. This is the little ring that divides the aorta from the ventricle. We looked a little higher up at the root and take very specific measurements. Here you see the 3 leaflets of the aortic valve very nicely. And we looked a bit further at the aortic arch, and again here. Those of you who are not familiar with CT scans, just imagine you have to lie on the floor and look up. So this is the right side of the patient, and that's the left side of the patient. And as an interesting sideline, as engineers collaborating with doctors, engineers look at buildings from the top down. So when we first started constructing beginning to construct computer models, we couldn't understand why we kept seeing mirror images. And it was because the engineers were looking down and we were looking up. So we were getting mirror images. So just one of the interesting things that happens when completely different disciplines start collaborating. So it's a strength to collaborate, but you have to realize there are differences. So we looked at the preoperative and postoperative magnetic resonance images to see if there were any significant changes in the aortic size. And then we wanted also to see if the aortic wall was thickened, which it was. And I don't have time to go through this, but this paper was accepted in one of the big American journals. And whereas you normally get a fairly miserable response, we actually were told that our statistical analysis was exemplary, which was quite nice. So the results were that the mean age of the patients was 33. The largest root diameter was nearly 45. Anything above 40 in an adult is abnormal. And the mean duration of the follow-up after the operation was about 6 years. And this is the aorta stretched out. So over here is the heart, and this is the aortic root. There's the coronary artery. That's the annulus, sorry, this is the aortic root, the coronary artery, stretched out. And here, of course, is the sleeve, and that's the beginning of the arch, all stretched out just to illustrate to you the absolute changes in diameter. And you can see that the part of the aorta that protected by the sleeve shows absolutely no change in the diameter. There's a little bit of change in the distal arch, which of course is not protected. So having shown that this is effective in preventing root dilatation, maybe we should apply pairs at smaller aortic root sizes earlier in the natural history of the disease. Because we know that the section can sometimes occur at diameters less than the cutoff point. So this is an old slide, the diameter of the aneurysm from less than 3 to more than 10. And dissections tends to occur beyond the red dotted line, but a few dissections occur down here as well before you reach the magic line. But now the line has shifted a little bit to the left, and 45 millimeters is now the international guideline number for recommending an intervention for operations such as the Bentel operation or valve sparing. So I'm conscious of time, but we've done a lot of experimental work, and this is in sheep. This is just to show you a sheep aorta, which has had a piece of dacron put around it, and you can see there's a gap between the aorta and the dacron. But this is our material, Tal's material, and it's completely welded. This picture on the right shows the very odd abnormal flow patterns in a Marfan aorta. You see all these blue squiggles indicating turbulent flow, whereas having put the sleeve on, we now get linear flow, which is much better, much more efficient. And we have a number of other slides here and pictures, which I really don't have time to go into at the moment. Very recently, our colleagues in Leuven have looked at longitudinal stress. Many people were concerned about transverse stress, but actually it's longitudinal stress that is important. And here we have a picture of a patient with a Marfan aorta before the pairs operation. You can see this is very enlarged here and also rather abnormally bent, whereas after the sleeve has been put on, there is less longitudinal displacement, as shown on the graph here, and also a much more normal shape. This is about to be presented in the United States at the GenTAC meeting next month. Now, this is not one person's efforts, although we must attribute most of the glory to Tal Goldsworthy, but there are many of us involved, and this is an incomplete list. Economically, yes, we think that there are decreased medical costs because you don't need to have a big operation and you're not committing the patient to lifelong warfarin. And we have spread around the world, and these are a few yellow dots, but essentially we have spread as I said before, to the northern and southern hemispheres. More than 200 patients with Marfan syndrome have received this, and the linked more serious problem of Loeys-Dietz also. And then there are a number of other conditions that we have now applied the technique to, some patients with bicuspid valve and some complicated congenital problems where we think it is helpful. So in conclusion, ladies and gentlemen, the pairs keeps the aortic root size stable, prevents enlargement in the medium term, and seems to us a third way, in addition to the ventral operation, to the valve sparing operation. And to give you the latest news, as of the 30th of September this week, 370 patients have received a pairs implant, 250 men, 118 women, which makes 1,068 post-operative patient years. Thank you for listening.
Well, that's an amazingly comprehensive review. Can I ask the first question, please, and just say, if a patient's trying to decide which of these two operations is best for them, obviously they should discuss it with their cardiac surgeon. But the most important bottom line is, what is the mortality risk for both of them? Is it now equal?
Well, the mortality risk for the pairs is about 0.2%. We have had one early death, that is 5 days post-operatively. And we've had two late deaths, but none of them actually related to the pairs operation. The mortality for the Bentel operation is around 1%, probably about 1 to 2% really. And the valves sparing root procedure are similar. So in fact, our operation has a lower early mortality than the two conventional operations now being offered.
Thank you. Victoria, do you have any questions from the audience?
Well, we invited people to email questions beforehand, and an anxious 40-year-old man has written. He underwent aortic root replacement surgery some 12 years ago, and he's since had 2 yearly MRIs. He's now 40 and he finds that COVID has interrupted things. His MRI is now a year overdue with no appointment in sight. Should he be unduly concerned? Should he seek a private appointment?
Well, I think if he is well, and hopefully he does take his blood pressure regularly, if that is stable and he feels well, I don't think he should be overly concerned. Ideally, he should have his MRI at the institute where he had it before, because you need radiologists to be able to follow the pictures. If you go somewhere completely different, then you're going to get some false ideas, and it's going to be confusing. So provided he's well and his blood pressure is stable, I think he should aim to get the MRI done in 2021. And I hope by then things will have been back to normal.
Thank you. He needs continuity then of care.
Continuity of care is essential, yes.
I think Kerry Reeves has her hand up. If Kerry would like to ask the question.
Hi, unfortunately, it's too late for my son to have the pairs. He's already got a mechanical valve. But a question I think would be relevant for others who are in the same situation. There is a replacement for warfarin for people who haven't got a mechanical valve. Is there any sign of things like that coming in for people who've got mechanical valves? And interrelated to that is, it's been recommended that my son has his own INR testing machine, but unfortunately our GP surgery are putting any excuse up, even though it's been recommended by his surgeon. So interrelated questions from me, please.
Okay, I'll try and answer some of those questions. Yes, there are oral thrombin inhibitors that are being used instead of warfarin, but there has been a lot of reluctance to use them in patients with valves. They're used in patients who've had deep vein thrombosis, and they're used in another group of patients who have irregular pulse, atrial fibrillation. But not everyone is happy to use it for patients with aortic valves. And the reason is that although from the patient's point of view, the oral thrombin inhibitors is good because you don't have to have these blood tests regularly. On the other hand, you can't monitor the level of anticoagulation. So that's the downside. And unfortunately, these oral thrombin inhibitors do have an effect on the enzymes in your liver. It was hoped that that wouldn't be the case, because that's one of the big features of warfarin. If you're on other drugs with warfarin, then you can get into problems because of the effect of warfarin on the liver chemistry. So I think the oral thrombin inhibitors are not the best alternative to warfarin, sadly. You have to remember that not all patients with Marfan who have an enlarged aorta are suitable for PERS. We can't offer it to people where the aortic valve is leaking badly. It's not an operation to deal with a leaking aortic valve. If there's a mild leak of the aortic valve, most of the time we can correct that with PERS. But if it's significant, moderate or severe leaking aortic valve, you need either a repair or a total replacement. I'm not sure I've answered all the questions, so please come back to me.
No, it's just the one about having your own INR testing machine, which...
Yeah, well, it's expensive, but I think ideally, yes. If you were living in Scandinavia or in Germany or in the Netherlands, you would have your own INR machine. But for the first 6 months, you need to have parallel testing in the clinic as well as with your tester. So I think the down payment is something like £600 still, but it's a worthwhile investment. I mean, if I was having to take warfarin, I'd certainly pursue that. So I think have to keep nagging people to do it.
Yeah, the problem is my son is 25. It means he has to miss work every week.
Exactly.
To get his INR tested.
Yes, probably takes a day by the time you travel to the clinic waiting for the results.
Luckily, it's in our GP clinic, so it's not so bad, but still, and our GP just won't support, because they'd have to support him having his own machine, and they just put up any excuse. The excuse changes, but it's still an excuse every time.
Professor Pepper, can I just make a point?
Yes, Nitha.
Hi, it's Nitha Nackford from the
Good
Brompton.
morning.
So I'm one of the paediatric cardiologists. So I'm so sorry this has happened to you regarding the machine. And I would just say, definitely, I support Professor Pepper. Keep fighting for that, because we give it to all the children. Fortunately, we're in a situation where our charity, the Brompton Fountain, funds it. And we used to do exactly as Professor Pepper said. For the first 6 months, we would ask people to keep going to the hospital. But actually, since COVID, maybe going to the hospital hasn't been the ideal thing. So we've actually changed that now. And we found that people can manage it very easily. So I think if you're really having trouble, then you may be in a situation where maybe try your MP, see if they can help you, because you can say that you know that other hospitals are giving it to their patients.
Okay, thanks.
Okay, thank you.
Thank you.
Tori, anybody else wanting a question asked?
I think Mr. McGreevy, Top Gun, had his hand up.
Yeah, hi there. Hi there, Doctor. My daughter is currently receiving losartan, and we haven't had any heart problems to date. Is that the latest drug to receive, or has there been any further developments?
Well, the losartan is a group of drugs, one of a group of drugs called angiotensin receptor blockers, and it is certainly effective. It's not more effective than beta blockers, but it's effective. There is another drug that called irbesartan that Dr. Anne Child knows all about, and her AIMS study looked at that. There are one or two small advantages of irbesartan over losartan, but Anne Child might want to comment on that. But I think if you're on losartan, that's a sensible thing to be on. Are you on a beta blocker as well, or is he on a beta blocker as well?
No, she's just on losartan.
She's just on a, well, that's good, because it's much better tolerated than a beta blocker. So I actually would stick with the losartan, but Anne Child is quite zealous about irbesartan and might have a different view.
Well, we've invited Professor Graham Stewart as the next speaker to talk about that. He's going to give you a report of the whole AIMS trial, but many of you may have helped us with that trial. We used the cooperation of 200 patients throughout the UK for 5 years. And we found, amazingly, that the children responded even better than the adults did. Also, they had very few side effects. So I would tend to think that irbesartan, especially for children, is a slightly more suitable drug than losartan. However, most cardiologists seem to be pretty wedded to losartan because they're used to using it. So if you want to change to irbesartan, you'll need to have a chat with your cardiologist and try and persuade them to try it. Mainly it's used if the child doesn't respond well to beta blocker or to losartan. But nowadays it's been adopted so that it can be a drug of first choice. But if you want to ask that question again of Professor Stewart, who's speaking at 10:50, I think you'd probably get a more full answer.
Okay, great. That's great. Thanks very much.
Any more, Victoria?
Tarquin would like to know of Professor Pepper's views of the factors influencing when to intervene with a PAERS procedure in addition to the default 45mm threshold.
Okay, excellent question. Well, we now have 370 patients, so we have grown in confidence with this operation. And we think we would like to see any patient with PAERS at any aortic size. And if there is some evidence that the aortic root is enlarging, then we would recommend PAERS. Now, there are some patients for whom we can't recommend PAERS. I've mentioned one problem already. If there's severe aortic regurgitation, it's not suitable. But there are also some anatomical reasons sometimes why we can't do a PAERS. They're very unusual situations, but sometimes people have very anomalous coronary arteries. Instead of having the normal arrangement of a left and a right coronary artery, they may have 3 coronary arteries, or they may have coronary arteries that wind themselves around the aorta before they go to the heart. These are unusual things, but if present, they would stop us being able to do the PAERS. So the majority of patients would be suitable for PAERS, but to assess it, we need to do a very careful CT scan with very much finer cuts than you would have in a normal CT scan.